Very good. Thank you, Jeff. I'd like to invite you to fire away and come up with questions. Who has a question here for either Jeff Weber or Axel Hauschild or myself? I have a question to Jeff. Jeff, the NY-ESO-1 story. Is NY-ESO-1 HLA restricted? So in other words, is there an HLA story with ipilimumab, or are we discussing a non-HLA restricted story there?
I think you're discussing both.
Okay.
There are both NY-ESO antibodies and NY-ESO T cells seen.
Yeah.
Most commonly you see CD4 cells. You can also see CD8 cells. And because you see the CD4 cells, no surprise, you would expect there would be T cell help to generate an antibody response. So both of those things have been seen, and that's one more parameter that begs for prospective validation in larger numbers of patients.
Right. So in the adjuvant ipilimumab trial, the EORTC 18071 trial, we will evaluate absolute lymphocyte counts, and so we can then retrospectively see whether a certain pattern at 2 months or 3 months of IPI treatment would give rise to an early biomarker that would be predictive for having an effect, yes or no. So this could be quite interesting biomarker for ipilimumab. Jeff, yes?
Certainly, the field is begging for biomarkers. I have to give a talk at the FDA on this, and it's going to be a very short talk because we don't have very good biomarkers in immunologic therapy. But I have a question for you.
Yes. This sounds ominous?
Not at all.
Oh.
Have you ever tried in the Morton MSLT1 data? Remember you made the point about the difference in survival being not a randomized comparison.
Yeah.
Have you ever tried, and then you said this could be due to the fact that many microscopically sentinel node positive patients with minimal disease may do perfectly well and never ever relapse. Have you ever tried to reconstruct from Morton's data what percentage of patients would have been in that category to subtract out those patients to see whether they actually account for the difference?
Yeah, actually we did that exercise, and I think Alexander van der Kooi is going to show that calculation. Interestingly, we have in our database a 12.5% or 12.5 to 15% patient population with submicromets. The interesting thing is that if you make the calculation on the MSLT1, that's the percentage that you're going to hit. I, of course, didn't want to show the slide because Alexander van der Kooi made the calculation. It's his credit, and he should show the slide. It basically means that we think this may be real, and it's not very far-fetched that you would have this type of a percentage of biomarker false positivity. Not that we are denying that there are melanoma cells there. No, of course there are melanoma cells there. The point is that it's a stage or a biologic phenomenon that does not necessarily lead or is followed by progression and death. And let's not forget that you have these data already sitting around on the shelf for 20 years in the Riedmüller trials here in Germany, very big trials on minimal residual disease in ovarian cancer patients, in breast cancer patients, gastric cancer patients, colorectal cancer patients, all showing similar type of percentages where people do not progress to avert metastatic disease later on, although they have been diagnosed 5 years, 10 years before with undeniable proof of involved bone marrow. So, you know, there's a lot that we don't understand in cancer, and tumor dormancy is one of those things. But it remains now a thing that will be followed up, and I think to do a prospective registration study is a correct thing to do. Let's not also forget that ultrasound is now such a phenomenally good tool that you, by following up with ultrasound after a sentinel node biopsy, even for a positive sentinel node biopsy, would detect micrometastatic disease in non-sentinel nodes later, if there were to be that phenomenon at a 3-4 millimeter tumor load involvement. So I think it's always a race about technology that will challenge an invasive methodology by a non-invasive one, and technology usually changes our lives every 5 years or every 10 years, and it's not unlikely that this will happen here with ultrasound. Yeah.
Lex, may I ask a question to Jeff, because he has by far the greatest experience with the drug and patient management. I have treated roughly 40 patients with CTLA-4 antibodies, with both CTLA-4 antibodies, but it's my impression that the management of autoimmune colitis and diarrhea is very crucial, because this is what the suffering, most of the patients are suffering from. It's 1/3 of our patients. So we used in 2 patients where it was refractory to conventional treatment, Remicade, with good success. In both patients, diarrhea stopped. But do you have any predictive tools? You have a question in the patient medical history to patients if they had GI problems in the past. Is this predictive for having more GI toxicity? Or you have any tips for us, insider tips for the management of those patients?
That's a very good question. Most of the patients do very well with simple high doses of steroids, but the initial mistake that I made, this is some years ago, was to give a brief course of steroids. You really have to give someone 20 to 30 days of steroids and start at 60 or even 80 milligrams. The infliximab or Remicade is a phenomenal drug. Within 24 hours, someone can go from having 10 diarrheas a day to none, and they can go from feeling miserable to feeling fine, which would certainly speak to the presence of elevated levels of TNF in the serum. There's a fellow in San Francisco, David Miner, who published, I guess, a case of several, maybe 1 or 2 patients, where he just gave the infliximab right off the bat. And at some point, we'll probably have to find out if just blocking TNF early on would abrogate the side effects without harming the potential clinical benefit. And I must say, in my experience, it's been the opposite. I've probably not seen anyone get infliximab and rapidly progress thereafter.
Right.
Same with the steroids.
I would like then to end by making the following remarks. It's clear that in the field of advanced melanoma, we are now into a new time frame where there's a number of targeted drugs emerging that could be quite interesting, but that this new method of immune modulation is clearly providing us now with results, if the dose and the schedule is right, where the 2-year survival rates in first line of above 50% and in second line of above 30% hint at a general activity level that cannot be detected alone by the response rate, but apparently also slows down progression of disease, not only measurable in prolonged stable disease fraction, but apparently seems to hint even at a slowdown of progression disease in patients that do progress. And so by the response levels and rates, we seem to underestimate the activity of this drug. What Jeff has clearly shown is that the manageability of this drug rapidly increases, and it's a safe drug to use, but you have to have, like the vigilance of a Jeff Weber, to do so well. That means then that it begs for the question, can that be installed by paradigms, by models, and they have been developed, and they do work, Jeff. Out there in the very expanded trial experience now, it has been demonstrated that what you have developed in terms of protocols really does work, and that the instruction of the patient is also crucial, right? Jeff?
I realized that Axel had mentioned he was treating a patient with high-dose IL-2, which we do at our institution frequently. If I were given a choice of treating a patient with high-dose IL-2 or ipilimumab, which is a choice I actually make fairly frequently, I would choose ipilimumab any day of the week.
Sure.
It's not just that I think it's an active drug. I think they're both active drugs. It's the management of high-dose IL-2 is hugely complex, and it's not the toxicity. It's the level of attention required for an inpatient expensive therapy which is why that therapy is never going to make it in Europe, in my view.